All right, it is noon. Welcome everyone to our last lecture in our seminar series for the summer. Thank you for joining us today for today's webinar. My name is Lauren Schwartz and I am the program chair of the Pennsylvania Association of Pathologists. Today we are presenting cases in head and neck, surgical, and cytopathology, highlighting pearls and pitfalls, presented by my colleague, Dr. Jalal Jalali. Just a little housekeeping before we get started. Everyone's mics have been muted and will remain muted during this webinar. If you have any questions during the presentation, please type them in the Q&A box located in the lower toolbar. I will bring them up at the end of the presentation and we will get to as many as we can within the QA session. If you need technical assistance, please type your need in the chat box and we will have someone reply to your request. Today's webinar is being recorded for training purposes and will be available. Today's agenda, Dr. Jalali will speak from approximately 12 to 12:45. Then we'll have Q&A and we'll get you all back to work by 1 o'clock. You can see on the screen now the information for getting CME. Dr. Jalali has nothing to disclose. And this information will actually be shared with you and will be shared again at the end of the presentation so that everyone can get their CME. Now let's learn a little bit about Dr. Jalali. Jalal B. Jalali is currently an assistant professor of pathology and laboratory medicine at the University of Pennsylvania. He signs out head and neck, endocrine, and cytopathology. He did his residency at Washington University in St. Louis, followed by a surgical pathology fellowship. Then he completed a cytopathology fellowship at the Perelman School of Medicine at the University of Pennsylvania. His research focuses on HPV-related squamous cell carcinoma of the oropharynx. He's also interested in salivary gland neoplasms. Now, without further ado, we will turn the time over to Dr. Jalali.
Thank you, Dr. Schwartz, for this kind introduction. Can you see my screen? All right, so as mentioned, I will be talking about cases, interesting cases in head and neck, and focusing both on cytology and surgical pathology because both of those topics are dear to my heart, and I have nothing to disclose. My talk today is divided into two parts. The first part, I'll be talking about cystic lesions of the head and neck, and focusing on those with a squamous line cystic lesion. Now, I could have spent the entire hour or 45 minutes talking about cystic lesions in the head and neck, but I decided to keep it more interesting to include a second part where I'll be talking about a rare case of a spindle cell neoplasm of the maxillary sinus, and that will give me a chance to talk about spindle cell lesions in the head and neck, which we don't really commonly see every day. So moving on to the first part of the talk, when thinking about cystic lesions of the head and neck, location is extremely important. Location can tell you a lot about the differential diagnosis, and generally speaking, cystic lesions of the head and neck can be divided into two categories: those that occur in the central neck or in the midline, and most commonly the congenital lesion would be the thyroglossal duct cyst. But there are other also that can occur in the central neck, such as the dermoid cyst, the thymic cyst. The thyroid itself can have cystic lesions, but you also have to think about the parathyroids because those can have cystic lesions as well. And then don't forget that the sublingual gland is in the midline, and that can also have cystic salivary gland neoplasms as well as a mucocele, and in that location it's typically referred to as a granula. Moving on to the lateral neck, the most common congenital cyst in the lateral neck is the branchial cleft cyst, but also other important organs that are in the lateral neck would include the parotid. Usually it will be lesions in the tail of the parotid gland, but you can also have lesions that are occurring in the submandibular gland. To complicate this further, we have also scattered lymph nodes throughout the neck, and those can be central in level 6, but they can also range from level 1 up to level 4 and 5. So it's always a good idea to communicate clearly with the performing radiologist or clinician about the location of the lesion that is being FNA'd. So with that background in mind, let's move on to the first case. This is a 56-year-old man with a right neck mass noted about 2 months ago. This mass has been slowly increasing in size, and of note, this patient has a history of a papillary thyroid carcinoma about 20 years ago. You can see here the mass on CT scan, where the mass is actually hypodense. It's quite large. It's about in level 2A, and it has a enhancement of its wall with some thickening and complexity. So a biopsy and an FNA were performed, and I'm showing the biopsy first. And you can see here in this biopsy that there are scattered fragments of lymphoid tissue, kind of lined by squamous epithelium, and also scattered about our fibrous fragments with some maybe skeletal muscle in the background and some blood. Taking a closer look at this, at these cellular fragments, you can see that there is squamous mucosa that looks similar from bottom to top. There's not much maturation going on, but it does not look obviously dysplastic or cancerous at this level, but definitely noting the fact that it's not maturing quite nicely, and it's lined by this lymphoid tissue. So certainly some worrisome features, but on higher power, you can see that there's some increased mitotic activity and maybe some apoptotic debris in the lining of the cyst. So certainly on higher power, it's definitely concerning for something worrisome such as a malignancy, but it's not screaming malignant. But let's see what the cytology shows in this case. So in the diff-quick stain, you can see that there are scattered squamous cells in the background. There's some necrosis going on in the background. There are abnormally shaped squamous cells. Also a lot of cells with increased NC ratio, such as these cells here. And also on higher magnification, you can see squamous cells with irregular nuclear membranes. So certainly worrisome features for squamous cell carcinoma. The Pap stain also confirms those findings, highlighting the necrosis, but it's also nicely highlighting the squamous nature of this lesion with this orangophilia in the squamous cells. Definitely hyperchromagia in a lot of these cells, indicating that they're abnormal, and you can see here a nice fiber cells that is diagnostic of squamous cell carcinoma. So this patient underwent a primary workup, and they identified the primary to be in the oropharynx, and specifically in the base of tongue. And the patient underwent a palatine tonsil and base of tongue resection with neck dissection. So here is the lymph node that was previously FNA'd and biopsied, and you can appreciate how cystic it is with only a rim of lymphoid tissue and lining epithelium. But within the cyst, you can appreciate also quite the complexity with some septation and some solid areas, and those features will become important when I talk later about the radiology of these lesions. You can see here that even though now it's obviously malignant and squamous cell carcinoma, when you get a small, tiny, fragmented biopsy like I showed earlier, the diagnosis of malignancy can be a challenge, and if you're not thinking about it, it can be a pitfall. But fortunately, looking closer at these lesions with cytology, you can definitely arrive at a malignant diagnosis. This patient indeed had a squamous cell carcinoma involving the base of tongue and the tonsil. And you can see here the tonsillar epithelium that is not involved by tumor, and you can see here the crypt epithelium where usually the HPV infection happens and leads to a non-keratinizing squamous cell carcinoma that we see here in this case, and this indeed was HPV related, as you can see here, by the positive HPV P16 testing, which is a surrogate marker for HPV. So how common and how frequently do we see neck masses and metastatic squamous cell carcinoma without a known primary? Actually, it turns out to be quite common. In approximately 50% of patients with head and neck squamous cell carcinoma, about 44% of those will present with a neck mass initially. And if you look at those that are HPV positive, that frequency is actually higher in those patients. It's important to think about squamous cell carcinoma and the head and neck as two different biologically distinct groups. Traditionally speaking, the typical squamous cell carcinoma that we think about in the head and neck usually is of the keratinizing type. This squamous cell carcinoma usually affect older individuals and usually affect patients with a heavy smoking or alcohol use. And morphologically, it also looks distinct. It has polygonal tumor cells with a lot of cytoplasm and frequent keratinization. And when these tumors infiltrate, they induce quite a bit of a desmoplastic tumor response, as you can see here in these nice pictures. On the other hand, the HPV-related squamous cell carcinoma, which most frequently affect the oropharynx, appears different. It's usually of the non-keratinizing type, and you can see here that these tumors frequently have abundant mitotic activity and apoptotic debris. They frequently have areas of necrosis, and usually they don't have really nice distinct cell borders, as you can see here in the keratinizing type. They usually have a syncytial growth, and the cells have a spindly or oval shape-like appearance, unlike the typical keratinizing squamous cell carcinoma. Now, sometimes these tumors that are HPV-related can show areas of maturation or keratinization, as you can see here. But frequently, even though they show that, usually you will find the non-keratinizing areas in the background. And these are sometimes referred to as the hybrid type squamous cell carcinomas. The morphology is important, and the reason for that is by itself, it does predict survival. So there are studies that show that the non-keratinizing squamous cell carcinoma and the non-keratinizing squamous cell carcinoma with maturation have a better overall survival and a disease-specific survival compared to the just keratinizing squamous cell carcinoma. But nowadays, we know that the true driver for this is actually HPV and not the morphology alone. And HPV squamous cell carcinomas can have different morphologies. Most frequently, they will be non-keratinizing than non-keratinizing with maturation, but HPV-related squamous cell carcinomas can affect the basaloid type, the papillary type, the adenosquamous, lymphoepithelial, and verrucous type, and as well as the keratinizing squamous cell carcinoma with varying frequency. Usually when you're dealing with a keratinizing squamous cell carcinoma from the oropharynx, typically those will be more likely to be not related to HPV, and they can be related to HPV in 30% of cases. Nowadays, with the CAP guidelines, P16 has been shown to be a reliable surrogate marker for HPV in the oropharynx, and typically the cutoff for positivity is 70% strong to moderate nuclear and cytoplasmic staining. And you can see here that it definitely correlates with HPV in situ hybridization, which can be used in certain situations when, especially outside of the oropharynx, such as the nasopharynx. But what about HPV testing in cytology specimens? It is generally divided into cell block-based testing and also liquid-based HPV testing. The cell block-based testing, you can use the P16 immunohistochemistry, similar to surgical pathology specimens. or you can use DNA in situ hybridization or RNA in situ hybridization. Among these three, RNA in situ hybridization is probably the most sensitive and specific, but is not widely available, and therefore P16 is still frequently used in cytology specimens. Now, the liquid-based HPV testing was mainly validated and is used more frequently in GYN specimens and pap smears, and the different platforms are widely available in cytology lab. And a lot of studies recently have shown that liquid-based HPV testing can be reliably used also in head and neck cytology specimens. So when dealing with P16 staining in cell blocks, what do you use as a cutoff for positivity? There are many studies out there with variable cutoffs, but we have reviewed these studies recently and shown that false positivity in P16 in cell blocks is extremely rare. But having said that, it's not similar to surgical pathology specimen. Usually the cutoff for positivity that correlate with surgical pathology specimen is much lower. So around 15% if you see strong nuclear and cytoplasmic positivity in cell block, usually those cases will correlate 100% with surgical pathology specimens. The problem with cell block P16 staining is actually the false negativity, because it can be up to 20%. Therefore, when you're dealing with a negative P16 staining in cell block, it's better to repeat the stain in surgical pathology specimens. Now, if you lower the cutoff too much for positivity and call any cell staining, many of the times that will correlate with surgical pathology P16 positivity. However, there are studies out there that show that if you lower it too much, you may end up with increasing your false positivity rate, and therefore it's still recommended that you would repeat staining if it's between 1 and 10%, and report those as equivocal. So moving on to a second case that has a similar history to the first one. This is a 37-year-old woman also presenting with a lateral cystic neck mass. This neck mass, as you can see here, is hypoechoic, and it has acoustic enhancement, so truly cystic. And it's in a similar location to the previous mass. It's in level 2A. And based on radiology, it's the differential diagnosis includes an abscess formation or less likely a metastasis to a cystic node, but it also includes a branchial cleft cyst. So let's look at the FNA that was performed on this case. As opposed to the first case, you can see here that these squamous cells in the Diffquick and Pap stain are still maintaining a low NC ratio. Their nuclei are quite round with smooth nuclear membranes. And you can see here that even though in the Diffquick there's a background debris, and in the Pap there's some degeneration, there's not much of necrosis going on in the background. So overall, features of a benign squamous lined cyst. Indeed, the surgical pathology excision of this cyst confirmed that impression, and you can see here that compared to the previous case, we can see that the squamous lining is nicely maturing, and you can see that by the fact that it's accumulating more cytoplasm as opposed to the basal cells, which have less cytoplasm. And it's also has a lymphoid tissue in its wall, and you can see here that it's quite cystic throughout. So all of these features combined with the radiological appearance and location of this is diagnostic of a branchial cleft cyst, which are the most common congenital lateral neck cysts, as I mentioned. Most of these arise in patients between 20 and 40 years of age. So even though it's a congenital lesion, it's not very frequent in patients below the age of 5, it has been shown. And more than 90% are derived from the second pharyngeal arch. And however, there are branchial cleft cysts that can occur from the first branchial arch in about 5 to 8% of cases. And those are usually associated with ear kind of abnormalities, like ear discharge or a pit around the ear, because that's the location of the first branchial arch. The third and fourth branchial arch cysts or sinuses or fistulas are the least common, and usually those can be associated with a pit around the piriform sinus. And so the cases I presented are kind of classic cases from both entities, and you can see here that the morphology is very different between the two, the benign squamous cells and the really atypical malignant squamous cells. But we all know that real life is not perfect. Here's a glimpse of the third case that I'll be presenting that shows a lot of inflammation in the background, some perhaps atypical squamous cells. So what do you do with these cases, especially given the fact that the literature is full of cases that are benign and masquerading as malignant, or the other way around, where a cystic metastasis was initially missed as a branchial cleft cyst. What complicates this picture further is that about 10% of branchial cleft cysts can be infected, and that's usually the trigger that brings them to clinical attention and presentation, is that there is an infection that makes this cyst that was congenital and was there all this time apparent to the patient and their clinician. And in a recent kind of review of branchial cleft cysts, it has been shown that 20% can have atypical squamous cells and are reported as atypical cytologically. Now, the patient age and the patient population can certainly play a role in determining how suspicious you should be as a pre-test positive probability based on the before you actually look at the slide. And the incidence of unsuspected malignancy, depending on the population, can range from 3 to 24% in a cystic mass without a known primary. But you can see here that it can increase with the patient age, and in patients above the age of 40, it can be up to 80% in some populations. So with that in mind, what are some helpful clues radiologically as well as cytologically that can help you determine what to do with these cases? So radiologically, you can see that branchial cleft cysts are typically thin-walled cysts and not complex. They usually don't have septations or any solid areas, and typically they are single lesions. You can see here that one of the frequently mentioned signs for branchial cleft cyst is the beak sign, where the cyst is kind of wedged in between the internal and external carotid arteries. On the other hand, metastatic squamous cell carcinoma, like I've shown in our case on low power, is usually complex and have cystic areas associated with some solid areas and septations. And usually the wall is quite thickened and has enhancement in its wall. Problem is when branchial cleft cysts get infected, they can show overlapping features with these kind of complex features that you see radiologically, and therefore radiology alone is not enough, and you need cytology. So a recent kind of review or logistic regression analysis by Dr. Layfield that was published in Diagnostic Cytopathology looked at 19 features that potentially can help distinguish between branchial cleft cyst, and metastatic squamous cell carcinoma. So they looked at many different things like hyperchromagia, necrosis in the background, kind of cell shapes, and you can see the paper. But basically, the gist of that paper is that the features that are most helpful in discriminating between these two entities and avoid the pitfall between the two is when you see cells with high NC ratio, irregular nuclear membranes, and small clusters, that favors the diagnosis of metastatic squamous cell carcinoma. Whereas if you see mature squamous cells with a low NC ratio, a nice keratinization, usually that will point more toward the branchial cleft cyst. But as I mentioned, I'll talk about a case where it's not always clear. So here's a 74-year-old woman with a right parotid mass. It's about 1.3 centimeters, and you can see here that's around the tail of the parotid. Here's the mass. It's not that big. It has some thickening and enhancement of its wall, and it's hypodense, indicating that it's probably cystic. So an FNA was performed, and this was the FNA that I showed previously, with some kind of maybe high NC ratio squamous cells, a lot of inflammation and debris in the background. Granted, some of these squamous cells are degenerating, so there's some degeneration going on. But if you keep looking around this case, you cannot dismiss it, and it's indeed atypical. And the more you look at it, depending on your threshold, you may have different grades and gray zone, but you may end up with a suspicious diagnosis for squamous cell carcinoma, because some of these are really hyperchromatic and atypical. So what are some salivary gland neoplasms that can show squamous differentiation? It can affect both benign and malignant tumors, and some of these can indeed be cystic. Most commonly in pleomorphic adenoma and Warthin's tumor, when they undergo injury or a previous FNA, that's when they have squamous differentiation. But this lesion has not been FNA'd previously. So let's think about some malignant lesions. Mucoepidermoid carcinoma is the most common carcinoma of the salivary gland, and usually it can have epidermoid cells, so kind of almost squamous looking cells, but usually those do not keratinize, and also usually you have mucin or mucocytes in the background, which we don't see in this case. Carcinoma ex pleomorphic adenoma, usually those will have a long-standing history of a large mass with that was kind of benign and staying there, but all of a sudden started rapidly growing, and that's when you start suspecting a carcinoma ex pleomorphic adenoma. So that's not kind of the history in this case either. Metastatic squamous cell carcinoma is certainly a consideration. It can show up in the parotid gland, and it's certainly more common than primary squamous cell carcinoma of the parotid, which is extremely rare. Some salivary gland tumors that are least likely to show squamous differentiation that we can certainly exclude are oncocytoma, salivary duct carcinoma, and some of the non-neoplastic entities that could be entertained are kind of sialadenitis, which can have squamous metaplasia, especially with necrotizing sialadenitis, and also duct ectasia. So this case was signed out as atypical squamous cells, which is justified in a background of inflammation and debris, and therefore it underwent a surgical resection and a parotidectomy. And here you can see the follow-up surgical pathology specimen that shows a dilated cystic lesion here in the middle of the parotid. You can see here that there's a periparotid lymph node that does not look abnormal. And this kind of cystic lesion is sort of associated with these ducts. Looking closer at this lesion, you can see here that it is definitely inflamed. The wall is quite inflamed and it's quite thickened, which explains the radiology of this lesion. And the lining epithelium, you can see here that it certainly explains some of the atypia that we saw on cytology. But overall, it's not completely out of place with this background inflammation in the wall and not dysplastic. So it's kind of more of a reactive atypia. And the kind of clue to this is the fact that the shape of this cystic lesion resembles a duct, and that's why it's associated with these ducts in the background. So therefore, this is just ductictagia with squamous metaplasia and not even neoplastic. A similar kind of case in terms of findings, but not so much in terms of the clinical presentation, is this case of a 59-year-old man with a painful right neck swelling. This mass moves with swallowing, and therefore, kind of clinically and radiologically, they think that it's in the thyroid. And the FNA from this mass shows all of these kind of degenerated cells with a lot of macrophages in the background. And scattered about, you can see that there are squamous cells here. Some are kind of inky and hyperchromatic and not so much higher NC ratio, but certainly an unusual finding to see in a thyroid lesion or a thyroid cyst. So what are some possibilities? We all know that squamous metaplasia can affect follicular cells, and those can be either benign follicular cells or even malignant. It's known that PTC can undergo squamous differentiation, and even anaplastic carcinoma can have squamous differentiation. But it's definitely not that atypical, and we don't have the typical features of papillary thyroid carcinoma in the background with the follicular cells that show PTC-like nuclear features. Other possibilities, could this be a dermoid cyst or a thymic cyst? Both can be squamous lined, and usually the wall of the cyst will be helpful in arriving at the correct diagnosis, where the dermoid cyst will have some adnexal structures, whereas the thymic cyst will have some thymic tissue in the wall of the cyst. So this was signed out as squamous cell lined cyst and cystic debris, but underwent a lobectomy. And you can see here that in the surgical pathology specimen, we do definitely have a cystic wall here with some inflammation and normal kind of follicular cells in the background without any features of PTC. And looking closer at these cells, they certainly explain the cytological findings of the aspirate, where we can see some thin and flattened squamous cells and some more plumper squamous cells, but overall it is maturing quite nicely throughout. So we did a workup for this case, and indeed they are staining with PAX8 and TTF1, which indicates that they are derived from follicular cells. So basically this is just squamous metaplasia follicular cells involving a thyroid nodule that became cystic, and there's no evidence of malignancy or neoplasia. So squamous metaplasia, as I've shown in these two cases, cases 3 and 4, can be a pitfall, and they can, of note, affect both thyroid and salivary gland, both non-neoplastic and neoplastic lesions. And I've shown you the kind of differential diagnosis that you can think of when dealing with situations like this. So to summarize this part, I've shown you 4 cases, 2 of which were very similar in terms of the clinical presentation, but different radiologically, as well as from a cytological perspective, and 2 other lesions that show squamous metaplasia. I've highlighted the fact that location is extremely important, and with kind of combining the clinical history and radiological features, you can narrow down the differential diagnosis. But just to keep in mind is that the older the patient gets, the more concerned you should be about a hidden malignancy, and that's usually how clinicians approach these cases as well. So kind of I'll spend the rest of the talk with this part 2 case, where it will give me a chance to talk about some spindle cell lesions of the head and neck. So this is a 60-year-old man with a maxillary sinus mass. You can see here that the mass is enhancing, and it's occupying quite a bit of the maxillary sinus, and therefore it was biopsied. You can see here in the biopsy that we have some palatal mucosa with like squamous mucosa, some kind of sinuses with bone and tissue around them. But there's certainly this neoplastic process that is occurring between the sinuses. And looking closer at these spindle cells, you can see here that they're quite cellular and associated with these very interesting vessels with quite a bit of hyalinization in their wall. And you can see here that some of the vessels are kind of branching and almost staghorn-like in appearance. And the closer examination of these spindle cells show that overall they look on the bland side. There's not much of mitotic activity or atypia, and certainly no necrosis and no large, bizarre-looking atypical cells. So what is the differential diagnosis? Here's a list of possibility. Obviously, with these branching vessels, should think about solitary fibrous tumor, which can occur in this location. Globangiopericytoma is another kind of unique lesion that can affect this particular site in the sinuses. Peripheral nerve sheath tumors are frequent in the head and neck. Leiomyoma can be a possibility. And then another very unique tumor that affects the sinuses is the biphenotypic sinonasal sarcoma. So that certainly is a possibility. Other sarcomas are less likely in this location, but should be entertained. And then whenever you're thinking about the head and neck lesions, you always should think about spindle cell carcinoma or melanoma. So let's tackle these one by one. For solitary fibrous tumor, certainly the nuclei, here's a picture of one case, and you can see here that the spindle cells certainly can be a good fit for our diagnosis. They're usually variably cellular, so they can be highly cellular or less cellular. One of the things that frequently is seen in these is the kind of thick, ropey collagen, which we don't really have in our case, but it could be just a cellular variant. The branching vessels definitely is a good fit, and then we don't see any mitotic activity in our case. And one of the easy ways to diagnose this lesion would be to throw some immunostains. So these tumors should be positive for CD34 and STAT6. And STAT6 is basically a recently described marker. It will stain the nuclei, and it's due to the gene fusion that occur with its partner, as you can see here. Globangiopericytoma is another possibility. Usually those tumors are pretty vascular, and they are originating from the pericytes. And you can see here that the nuclei are quite rounder usually and more oval in shape compared to the spindle nuclei that we had in our case. But certainly with all the crush artifact coming from the biopsy and the fact that these tumors can be spindled sometimes, that should be still entertained. These tumors stain positive for SMA and nuclear beta-catenin. Another possibility is a peripheral nerve sheath tumor, and that's a very frequent possibility, especially in the head and neck. And usually in this location, interestingly, the peripheral nerve sheath tumor are not typically associated with neurofibromatosis. And schwannomas are certainly more common than neurofibromas. Their nuclei are characteristically wavy, as you can see here in this, and they would usually stain with peripheral nerve sheath markers like S100 and SOX10. Leiomyoma is extremely rare in this location, but because I talked about its partner, like the peripheral nerve sheath tumor, and just highlighting the kind of different cytology of the nuclei for these tumors, they are usually blunt-ended and cigar-shaped, and positive for SMA and Desmin. So here's our differential diagnosis again. I went through the benign stuff first because this was apparently low grade based on our morphology. But one tumor to think about also is biphenotypic sinonasal sarcoma, because those can be on the blander side, and as you can see here, they're usually more hyperchromatic and somewhat atypical, but you can definitely entertain that possibility. It is called biphenotypic because of the fact that these tumor cells will stain both with myogenic markers as well as peripheral nerve sheath markers like S100. So that will be in the differential diagnosis as well. So here are the panel that we did. We did a STAT6 and CD34, and you can see here that it was negative. That basically excluded solitary fibrous tumor. Desmin and SMA, those were also negative, so that would exclude the glomangiopericytoma and leiomyoma. S100 and SOX10 were also negative, so that basically excluded a peripheral nerve sheath tumor, but it also, based on the fact that biphenotypic sinonasal sarcoma is, should be staining for these markers, it also is excluded. Because of the head and neck location and kind of carcinoma always come into the differential diagnosis. Kind of a carcinoma workup was done, and that was also negative. So that would exclude also a spindle cell carcinoma and melanoma. And kind of the FISH analysis for synovial sarcoma was also done, and that was negative in this case. So this kind of left us puzzled, and whenever you kind of feel that as a pathologist, you always go back to the clinical history and dig more and talk to the clinician. So this patient apparently has a history of kind of a Paget's disease-like diagnosis. The patient has a low phosphate, elevated ALK phos. He had multiple fractures in the past, including multiple sites, as you can see here. So certainly, these findings raises the possibility of a phosphaturic mesenchymal tumor, because these tumors will induce osteomalacia. But typically, these tumors in the bone and soft tissue will have this extra cellular matrix material that get deposited, and that's something that we did not see in this case. But reviewing the literature, it shows that phosphaturic mesenchymal tumor of the sinonasal tract actually resemble solitary fibrous tumors or hemangiopericytomas more than they resemble the typical soft tissue phosphaturic mesenchymal tumors. And they can present with prominently hyalinized thick vessels. And in a recent analysis of cases, it has been shown that these characteristically will stain with SAB-B2, and SSTR2A, ERG, and CD56. So those stains were done, and you can see here that this is beautifully staining with these markers. And as I'm showing here CD34 because it's nicely highlighting the vessels and not so much the tumor cells. And ERG was positive in this case, only focally though. So this actually is diagnostic of phosphaturic mesenchymal tumor in this patient, which is a tumor that is been described since the 50s. And it's usually a tumor that we think about in the soft tissue and bone rather than in the sinuses. But when it occurs in the sinuses, it can have a different morphology, like I've shown in this case. The Widener and Santa Cruz kind of take credit for pointing out the term phosphaturic mesenchymal tumor, because these tumors overexpress FGF and 23, and that will basically lead to phosphaturia, and that's how by losing the phosphate in the urine, that's how these tumor will induce osteomalacia in these patients, and therefore the frequent fractures that this patient had. Usually, these tumors can be cured if resected, and they're usually benign, but there are phosphaturic mesenchymal tumors in the literature that were described as malignant, but it's usually a rare finding. And once these tumors are resected, usually the patient's kind of bone status and osteomalacia goes away and it is cured. So here are pictures of the typical morphology of a phosphaturic mesenchymal tumor, which we don't see in the head and neck, with this kind of extracellular matrix-like deposits and spindle cells. And as I mentioned, the majority are benign, but the morphology is different in the sinonasal tract. So to summarize part 2, the differential diagnosis of spindle cell neoplasms of the sinonasal tract is wide, but with kind of a good differential diagnosis and the use of immunohistochemistry, you can arrive at the correct diagnosis. Remember that phosphaturic mesenchymal tumor is a rare diagnosis in this location and can be a pitfall because it resembles a solitary fibrous tumor or a hemangiopericytoma-like appearance. And it is usually positive for these markers, so that's quite a specific panel that not many tumors will show. And that is basically it for my presentation. Thank you so much, and I'm happy to take any questions. I think you're on mute.
Thank you, Jalal. That was excellent. As I look in the question box, I don't see any, but we'll give it a few minutes. Sometimes we've had late questions pop up. And again, we'd like to thank everyone for joining us this summer for this series. It's still up in the air as far as what we'll be doing for the Pennsylvania Society meeting next year. But we will keep everybody posted. And if we end up doing more lectures, hopefully everyone will join us again. We have one question, but it just says, great lecture. Not a question. We'll leave it up for 3 more minutes, and then thank you all for joining us. For those of you that have to step off. Oh, question. Do you think it's necessary to say keratinizing - non-keratinizing and grade well, moderately, poorly differentiated for squamous cell carcinomas?
Right, so that's an excellent question. So in the recent CAP guidelines, the differentiation of oropharyngeal squamous cell carcinomas is something that typically we don't, the CAP recommends that we don't say anymore, because most of the times when you give a differentiation, it will be labeled as a poorly differentiated squamous cell carcinoma because it does not keratinize, but that can be misleading to the clinicians, and in that case, they may think that this tumor will behave poorly, even though because it's HPV related, it actually behaves better. So the CAP recommends against giving a differentiation for the HPV related or P16 positive squamous cell carcinoma. Nowadays, in the oropharynx, we divide these into HPV related and non-HPV related. Because HPV related squamous cell carcinoma can affect many different variants, including the keratinizing type, I personally like to give a keratinization status because that will help also the pathologist looking at a metastasis potentially to know what the morphology of the tumor looked like originally. And having said that, it does not always correlate. Sometimes you have an unkeratinizing tumor in the oropharynx, but when it metastasizes as a keratinizing type. So I hope that answers the question.
Yes, and I just typed, hopefully, a bit about what you said, so we have it for the record. Oh, wait, now we have more questions. How often do you see PMT?
So, I mean, I personally haven't seen that many cases. I sign out head and neck and endocrine pathology and cytology. So this was only my first case that I've ever seen in that location. So I would say extremely rare. Obviously, some of my colleagues probably or more senior have seen maybe more, but I can tell that it's not a very frequent diagnosis, and if you don't think about it, can be a pitfall.
Okay, and another question is, when do you do ISH HPV study? Do you do high risk group only?
That's another excellent question. So yes, we do the high risk HPV only because those are the ones that are going to affect the prognosis. And in the oropharynx, for surgical pathology specimens, P16 is enough on its own. But outside of the oropharynx, in the head and neck, P16 does not always correlate with HPV status. So the CAP would recommend that if the tumor is staining with P16 outside of the oropharynx, that you do HPV-specific studies, including HPV in situ hybridization.
And Jalal, this is just my off-the-cuff question, but do you know which HPV strains these are most associated with?
That's an excellent question. So in the oropharynx, usually it's HPV-16 in the majority of the cases, almost all, more than 90% of the cases. I recently described kind of nasopharyngeal, the HPV-related multiphenotypic sinonasal carcinoma. That is associated with HPV-33. So that's different, but it's kind of a different entity, and usually will have an adenoid cystic-like appearance, and unlike the oropharyngeal squamous cell carcinoma.
Interesting. And one of the other questions was, how do we access the recorded lecture? And once this lecture series is over, all of them, I believe, will be posted on the website, and our wonderful staff that helps with the PAP will help make that possible. So check back on the website within a few days to weeks. And seeing as there are no more questions, we'll give everybody 10 minutes back in their day. Thank you again, Dr. Jalali, for the wonderful presentation.
You're welcome. Thank you.